Dear colleagues and friends, I'm sorry I started late and I didn't expect this video also. This is surprising. Anyway, we have spent already 12 minutes. We'll go to the program straight away. The topic for the day is update on PARP inhibitors in ovarian and pancreatic cancers. You're all aware, PARP is an important enzyme, poly-ADP ribose polymerase, which is essential for maintenance of the genome, and it repairs the DNA strand breaks. And some mutations, especially BRCA and many other mutations, result in deficiency of this enzyme activity. We call this homologous recombination deficiency. This situation, there is a higher chance of incidence of triple negative breast cancer, ovarian cancer, prostate, and pancreatic cancer. So against these tumors, new class of drugs have been found to be very effective. We are going to discuss about this class of drugs today. So without wasting much time, we'll go to the first session. There are 5 sessions today, and I request all the speakers to stick to the time so that we can cover all the topics in time. And all the participants, the chairpersons and the speakers are all from Madras except Dr. Ashish Singh. He is in fact an insider. We know him very well. So I don't think we need to spend much time on the introduction of these people because everyone knows every other. So we'll go to the first session, going to be advances in genetic testing for ovarian cancer patients, sponsored by MedGenome. Thank MedGenome because they are going to do this genetic testing at a much affordable price. So I request chairpersons, Professor Lakshmi Narasimhan and Professor Manika Vasagam, to take over. And the speaker is going to be Dr. Prasad Eswaran. He's a medical oncologist from Mayat Hospital, Chennai. Professor Lakshmi Narasimhan.
Thanks for your short introduction and brief introduction regarding PARP inhibitors, the treatment of malignancies. Straight away, we will go on to the topic that will be delivered by Dr. Prasad Eswaran. Over to Prasad.
Thank you so much, sir. So good evening, everyone, and many more happy returns of the day to our beloved Professor Subramanian, sir. So I'll try to do justice to the time given to me. I'll quickly move on to the presentation. So the topic for the starting for the discussion is about what are the advances that we have right now for the testing in ovarian carcinoma. So I'll be looking at a few of the topics which will be covered in the subsequent slide about the testing in ovarian carcinoma. So what exactly are we looking at the ovarian cancer is that we do have drugs, mostly they are chemotherapy drugs, which would have a lot of side effects, but at the same time, it is quite non-specific. So we do have a few of the standard regimens up to about the 3rd and the 4th regimen, and beyond that, it's going to be more of a treatment of physician choice, and whichever drug which was not used in the previous lines would be used for the subsequent lines for prolonging the survival. So as we all know, it is going to be the taxane as a backbone first, and subsequently based on the platinum sensitivity, we would decide about the 2nd, 3rd, and the 4th and subsequent lines of treatment. So we all know that the first line treatment is the one which has the maximum benefit. So we do have about 18 to 20 months of survival, which is a progression-free survival that can be obtained in the first line treatment. And subsequently, as we move down the disease progression duration, the progression-free survival is less, and ultimately the patient dies. So what we really need to look at something beyond which can help the patient live longer, at least identify those patients who are capable of having a druggable target, and based on that, we will be able to give them a better survival. So overall, when we look at the ovarian carcinoma, the 85% of the malignancy is mostly sporadic, but still about 15% of the tumors are hereditary and they are familial, mostly caused by the genetic mutations involving the BRCA1 and the BRCA2. So we were looking at only the BRCA a few years ago, but since about 2019, as when most of the PARP inhibitors were FDA approved, the BRCA as well as the other genes or the mutations involved in the homologous recombinant deficiencies were looked into, and we were able to identify a lot more number of genes which were involved in the treatment of which were involved in the targetable mutation in the management of ovarian carcinoma. So we are looking at BRCA mutation, the other pathways which are involved in the homologous recombinant deficiency, the promoter methylation pathways, and there are few other genes which are involved in the HRD pathway. So overall, any of the deficiencies would lead to inability of DNA repair because of either internal or external damage, which can subsequently lead to genomic instability. And this genomic instability is the target for PARP inhibitors. So we know that it's a conglomerate of a lot of genes involved, which can subsequently lead to the genomic instability, and the homologous recombinant pathway is the error-free pathway which is able to repair these genes. So exploiting this genetic deficiency is the pathway, or is the route for druggable mutation to extend the survival of the patients affected with ovarian carcinoma. So we know the stability or the balance between the genomic the DNA repair and the defects in the DNA repair is very delicate and has to be properly maintained for a normal cell to have a good homeostasis. Otherwise, it's going to be much more difficult for the cells or the subsequent cells to have a tumor repair, and they goes in for malignancy. So we do have different pathways: a single strand break, double strand break, and there are also a lot of pathways which are involved in treating or repairing the single strand break, the homologous recombinant pathway, the non-homologous end joinings, and MMEG. All these pathways are all involved in the treatment of repair in the tumor. But when there are deficient, then we do have the mutation happening, subsequently developing into tumor. So the PARP inhibitor, which is essentially the target, which is essentially the drug used to target this, is able to have a very good outcomes in those patients who have this mutations. So when we look at the ovarian carcinoma, especially the high-grade serous ovarian carcinoma, we could see that BRCA mutation constitutes nearly about 25%, of which 15% would be more of a germline mutation, 10% would be associated with the tumor mutation, and the remaining 25% are caused by the remaining genes which come under the family of HRD group. So this is the pie chart which shows the different HR deficiency mutations which are involved in the treatment of ovarian carcinoma. So when we look at it, a proven HR deficient mutations along with the possible HR deficient mutations constitutes nearly about 57% of the repair genes involved in the ovarian carcinoma, especially the serous carcinoma. So what do we look? How do we look at? We need to either look at the cause of the HRD pathways, which is the gene panel, which is all the complement of the genes, which are quite difficult to remember, but we could get everything in the next generation sequencing panel. Or we could look at the effects of the HRD instability, which is expressed as genomic instability in the tumor. So generally, when we look at the tumor, what do we need to understand is that it is not a single score or the single mutation, but it is going to be a combined score of the loss of heterozygosity, the imbalances in the telomeric alleles, along with the Stahl scale state transitions. So all these as a combined score would give us the total HRD score, which probably when added with the BRCA mutation, which would be able to give us a very good score of whether that patient has a HR deficient tumor or a non-deficient tumor. So it is going to be the cumulative score which decides whether the patient has a HRD positivity or HRD negativity. So we do have different trials which have come up with different scorings, but probably the POLO and the PRIMA trial had come up with a HRD score of more than about 42, whereas the VILIA trial had come with a score of about 33 or more to define whether they have HRD positive or HRD negative. So this is the graphic representation of each of these genetic mutations, loss of heterozygosity, allele imbalance, and all these represent as an individual score. See that the cumulative score of 42 was able to give us a clear delineation of whether the tumor was susceptible for a druggable target or not, instead of using the individual score. So we could see a cutoff of 42 in the clinical trials had given a clear picture of whether the PARP inhibitors would be able to give us a clinical outcome or not. So in this diagnostic test, in which we involve the BRCA mutation along with the genomic instability score, combined score, we could see that when BRCA mutation is negative or any of the genomic instability status is positive, the overall status is considered as positive. Whereas in BRCA mutation is positive, irrespective of the presence of the other score, we could still take it as a positive test. If both are negative, then the disease is being labeled as HRD negative, and we may not be able to use the PARP inhibitors because there is no druggable target. So this is the pie chart which was used in the POLO trial, in which we do have the HRD positivity evaluated as the total BRCA mutation positive disease, which is nearly about 29%, and the overall score, irrespective of the BRCA, we could see nearly about 19% were involving the non-BRCA mutation. So overall, 48% of the high-grade serous ovarian carcinoma was positive for HRD. And when patients were evaluated based on their HRD status, including the BRCA, we could see the curves which were separating right from the beginning, by probably about 2 to 3 months time duration. We could see the curves separating. When we exclude the BRCA mutation and look at the other causes of genomic instability, still there was a difference in the progression-free survival when PARP inhibitors were used. So this is the test, which is a next generation sequencing, which is used for diagnosing the HRD score in most of the ovarian carcinomas. And this is how the report would look like. When there is a presence of genomic instability, it will be reported as positive, and what type of mutation had been seen in that particular tumor will also be reported, and the overall clinical significance of that mutation is interpreted for the clinical choice. So why do we need to do the BRCA mutation? So concentrating more on the BRCA status, we know the BRCA mutation is more responsible for multiple sites of tumor. It is predominantly the gene mutation which involves the breast and the ovarian, but it can also cause male breast carcinomas, prostate, as well as pancreatic carcinoma in the decreasing order. So we could see that the ovarian carcinoma patients who have BRCA positive disease will have a higher overall survival even in the first line treatment. They would have a higher complete response to the platinum based treatment, and even the subsequent treatments, they would have a better progression-free survival and a longer treatment-free interval when PARP inhibitors are used. So we could see that patients who have a germline mutation would have a better 5-year overall survival in patients who have this specific mutation. So when we look at the family members of the patient who has this BRCA mutation, it is ideally advisable to get the next generation screened properly and probably at the earliest age group, so that they can be counseled to have a proper screening for the most common breast or the ovarian carcinoma. We could see that patients who have the BRCA1 mutation have nearly about 39% of developing the ovarian carcinoma, and BRCA2 mutation will be having about 11% of developing ovarian carcinoma. And these patients, based on their risk strategy, they can be counseled to either go for a prophylactic oophorectomy or a prophylactic mastectomy, depending upon the other risk factors. So establishing this BRCA mutation in a patient who has the disease would be able to help us have a ideal treatment decision designed specifically for that patient. It is a very good prognostic factor because for therapy purposes, it's going to be of more of the platinum sensitivity, and the PARP inhibitors will be of very good use in such patients, and the family members can also be evaluated and they can be counseled accordingly. So whom to test? So we know the BRCA mutation is expressed in nearly about 47% of the ovarian carcinoma patients, though it is though there is no family history of ovarian carcinoma. When we look at the age distribution, BRCA mutation is still seen in the tumor of ovarian carcinoma patients who are more than about 50 years of age group. So it is always ideal to test the presence of BRCA mutation in all high-grade serous ovarian carcinomas. And it is if the testing is not done, we may be missing nearly about 40% of the patients who may have this mutation, and they may lose the opportunity to use the PARP inhibitors. So looking at the expression of the BRCA in different types of ovarian carcinomas, we could see high-grade serous carcinoma has the highest percentage of expression, and though the other histologies do have this BRCA mutation, they are seen in lesser percentage. So as per the recent guidelines, we need to have all the ovarian carcinoma patients evaluated for the germline as well as the somatic tumor testing at diagnosis when they are diagnosed with the ovarian carcinoma. So this had been clearly put up in the recommendation as category 1 with a strong recommendation in the 2019 ASCO guidelines, which was published in the JCO. So we do have country-specific guidelines which had been put in 2015. Various countries had endorsed the testing at diagnosis for the BRCA mutation in ovarian carcinoma, although there are certain countries which do have a different national guidelines. So what needs to be tested? So a patient comes to the OPD with ascites. So we do have the diagnosis of ovarian carcinoma based on the clinical and radiological factors, as well as the histological documentation or cytological documentation. So we need to evaluate the presence of both germline as well as somatic mutation in the tumor tissue as well as from the blood. So we could see that the germline mutation is mainly done from the blood sample, whereas the somatic BRCA mutation is done only from the tumor tissue. So all the patients who are diagnosed with ovarian carcinoma needs to be evaluated with both germline as well as somatic mutation. So there was one publication which had come from India, which was published in the JCO, in which the germline BRCA mutation expression in the Indian population is nearly about 22%. So it is quite a significant number of the expression of the BRCA in the Indian population. So we need to really get this test done in all the patients who have high-grade serous ovarian carcinoma. So we do have this publication which says nearly about 29% of the patients will have BRCA mutation, and even though when there is a negative family history, when sporadic ovarian carcinoma patients exhibit the histology of high-grade serous carcinoma, it is prudent to have the patient tested for both germline in the blood as well as the somatic mutation in the tumor tissue. So I wouldn't go into the specific of how we are going to do this test. It's going to be more complicated, but we need to remember that both the tests has to be done in all patients who have high-grade serous ovarian carcinoma. So let's look at a few of the international guidelines. As we do follow the NCCN guidelines, which classically recommends the testing for both germline as well as somatic in the ovarian carcinomas if not done previously. So we do have all the validated tests, the presence of genomic instability or the mismatch repair genes, which needs to be evaluated in all the patients with this malignancy. So the same guidelines had been endorsed in the recent 2021 update also, in which this based on the germline and the somatic mutation, we do have the options of using Olaparib with or without bevacizumab in the first line maintenance treatment also. So getting this test in the first line at diagnosis by means of next generation sequencing, it is going to be really important in having these drugs in the maintenance therapy, which probably would increase the tumor-free the treatment-free interval, and probably will have more patients coming as platinum-sensitive disease. So the guidelines were put up by the ESMO, the ASCO, and the Society of Gynae Oncology and all the societies have endorsed the testing of germline BRCA mutation as well as the somatic BRCA mutation in patients who have ovarian carcinomas. So what was the recommendation? I'll just go through the recommendation given in the guidelines. See, all the women diagnosed with an epithelial ovarian carcinoma needs to be offered germline genetic testing for BRCA and other ovarian cancer susceptibility genes. Somatic testing should be performed in women who do not have a germline pathogenic or a likely pathogenic BRCA variant. So the recommendation for testing has a category 1 recommendation, and it is the standard of choice. So what are the methodologies that is used for checking BRCA? We do have the Sanger sequencing, which is one of the initial testing method. But right now we do have the next generation sequencing and the recent techniques which can have a early turnaround time of detecting the mutation positivity. So Sanger sequencing was the initial testing, which was kind of time consuming, but with the advancement in the science and technology, we now use the next generation sequencing, wherein we do have a lot of advances in detecting ovarian carcinoma within a short period of time. So we do have this testing done both in blood as well as in the tumor tissue, in which the DNA from the tissue is extracted, they are analyzed, and the analysis of the DNA reports are interpreted for clinical decision. So how do we interpret a germline mutation? Germline mutation is classified into 5 classes, of which class 1 and class 2 are considered as non-pathogenic. Class 3 is uncertain significance. Class 4 would be likely pathogenic, and class 5 are the characteristic pathogenic BRCA mutations or any other clinically significant mutation. Whereas in the somatic mutation, we do have them as expressed as tier 1 and tier 2, in which we do have this clinical significance. Tier 3 comes under unknown clinical significance, and tier 4 and will be coming under the benign or the likely benign variants. So we need to clearly have this germline as well as somatic mutation represented either as pathogenic or tier 1 or tier 2 variant, so that these candidates can be a good, these candidates may be put on PARP inhibitors when they are diagnosed with ovarian carcinoma or any of the pancreatic or prostate carcinoma or male breast carcinoma. So any BRCA associated gene or a HRD deficient gene, when they are found to have a positive HRD mutation, it is good to have them started on the maintenance therapy with PARP inhibitors. Where to do the testing? So we do have lab specific criteria in which we need to get this testing done in specified labs who do have the expertise or the less error in identifying the test, or we need to have a place where the test specifics are showing less number of false negativities. There should be a good specificity of doing the test, and the failure rate should be less than about 1%. And of course, costing is one major factor, but right now the cost for BRCA had come down significantly, and it is quite patient friendly as of now in major cities. So what is the impact of doing all this testing? So basically it is mainly to assess the risk, put them on the treatment, and have them counseled for evaluation for prevention of second malignancy or the subsequent site, as well as to guide therapy management. So patients who have the ovarian carcinoma or a triple negative breast cancer, when they are diagnosed with the disease, they can be put on PARP inhibitors, which is going to be a very good treatment plan for the patients who are such malignancies. Should be tested. So the carcinoma patients, when the test has to be done, it has to be done at diagnosis. And what test has to be done? Both a germline as well as somatic mutation has to be offered to all patients who have high-grade serous ovarian carcinomas. So thank you so much for your kind listening.
Subramanian sir. So you'll have to unmute your mic, sir.
Thanks,
Lakshmi
Prasad. I think it was a wonderful lecture to learn. I think it's very useful lecture for the postgraduates, and we can update the laboratory knowledge that is will be implemented into practice in the coming years. We will go to the next session, sir. Subramanian, sir.
Yeah,
Yes, yes.
yeah.
I thank Dr. Prasad Eswaran for the excellent lecture. We'll go to the second topic, Olaparib in the treatment of pancreatic cancer. Chairpersons are going to be Professor Gangadharan. Rajiv Rajendranath couldn't make it, so I request Dr. Gangadharan to chair the session.
There's a small change in that, sir. Instead of Gangadharan, I'm chairing that because.
Nice. Nice,
Yeah.
Professor Manikvasan.
Thank you, sir.
Nice. So the speaker is going to be your colleague, Dr. Jovita, Medical Oncologist, SRMC Chennai. Take over, please.
Yeah, thanks for the opportunity, sir. I once again wish you, you have completed successfully 80 years and this should continue forever, sir.
Thank you.
Thanks, sir. I think, Jovita, you can straight away go to the lecture that is on PARP inhibitors in pancreatic cancer. May I call Dr. Jovita to take over the procedure.
Sir, I got logged off, so I'm just trying to reconnect. Yeah. Can I share the screen, sir?
Ma'am, you can share your screen. Ma'am, you'll have to turn the device audio on one of your devices. Jovita, ma'am, are you there? Jovita, ma'am, are you there? Ma'am, you'll have to unmute your mic. Sir, I think Dr. Jovita is having, I think she's connecting again, sir.
Sir, yeah. I think a technical issue here. Can you present my slides
sure,
so that I can?
Sure, ma'am. I'll just present your slides.
Yes.
Hello.
Hi, ma'am.
So can I start presenting?
Yes, ma'am.
Yes, I'm able to see the slide. Good evening, everyone. I thank Professor Subramanian and my senior professors for this opportunity, and thank AstraZeneca also. And I would grace showers of blessings upon my Professor Subramanian. He's a beloved professor and family friend as well. For all the endeavors he has, for all the ventures he has taken up, and for the way he has influenced many people's lives, both patients as well as his own colleagues and juniors. Thank you, sir, for that. Going into the topic, I'm going to talk on Olaparib in patients with germline BRCA mutation. Now, we all know that pancreatic cancer plays a menace in terms of the way it manifests. It's quite sinistric in the way it presents. And pretty much in the locally advanced stage is where when we are able to pick up most of the cases. And we see the prevalence in 2018 worldwide is around 2.5%. The patients with pancreatic cancer have a very poor prognosis. The majority will die within the first year of diagnosis. Next slide, please. In UK and US, you would see there's not much. Over a period in 1 year, there's only 20.8 to 35.3%, and 5 years it's just a single-digit number, and obviously in 10 it drops even further. Next slide. So we also see that there's not much improvement in terms of the results that we have had in the 1 year survival or 5 year survival or 10 year survival in CA pancreas and its management in comparison to other sites of malignancies like the lung, ovary, kidney, bladder, and so on. So we've really marched forward in the kind of results that we have had in other sites, whereas in pancreas, it's still a long way to go. And the next slide, please. There's a significant unmet need to prolong the disease control as a part of the first-line treatment. And we all know that we have very less number of options left in our hands. If we just opt for a 5-FU, we have hardly 1 month survival. And we all know that gemcitabine is the mainstay in chemotherapy. That forms the crux. And even then, we have only 3.3 to 3.7 months. And then we have gemcitabine with MAB, nab-paclitaxel, which again gives only 5.5 months. Recent studies have given us data that FOLFIRINOX has actually improved the survival. Next slide, please. Now let's go to discussing the role of BRCA in pancreatic cancer. Next slide. Now, molecular profiling studies have very clearly shown us that there are about 50% of the pancreatic cancer, there's no actionable mutation. In 23%, we have a lot of other pathways like the hedgehog pathway and the AKT, MET, and so on. In about 27% of the DNA damage repair mutations, we do see some important mutations such as the BRCA2, the PALB2, ATM, and the mismatch repair MLH1 and MSH2 gene mutations and so on. It would become, inappropriate if I wouldn't mention the other very important mutations like the KRAS, TP53, and the CDK N2A and the SMAD4. And we all know that by the loss of SMAD4 expression in the pancreatic cancer, it portends a very poor survival and prognosis. And expression of this PARP, which is nothing but a secreted protein, acidic and rich in cysteine, that is a SPARC expression within the peritumoral stroma, actually signifies that the patient is going to respond well to nab-paclitaxel and gemcitabine. We also have other things, gene tests like the STK11, which is a tumor suppressor gene, which is expressed in Peutz-Jeghers syndrome. And also we see that we have this HENT1, which is called as a human equilibrative nucleoside transporter 1, which if is expressed well, that means that the prodrug gemcitabine will be taken in well by the tumor cells, and so the cell death is going to be better. So, but we don't have a proper biomarker to check for this HENT1. So that is a drawback, and we are yet to evolve in these areas. Next slide, please. So we see that in the estimated 5 to 7% of all our patients with pancreatic cancers have BRCA mutations. In the general population, it is 1 in 15. And if we would see the comparison of BRCA 1 and 2, in pancreatic cancer, BRCA2 mutation is what is important, and the ratio is 1:3. And this prevalence actually varies depending upon the geography and the ethnic group. Ethnic group, as in when we say that, most of the times we think of the Ashkenazi Jews, because that's where we see the BRCA2 mutation. And the germline BRCA mutation have a 2.3 to 7-fold increased lifetime risk of developing pancreatic cancer. And off and on, we see a lot of young people who are affected with germline mutation, the mean age between 62 to 70 years. That's what is generally expected. But if we see a young person with pancreatic cancer, then it is imperative that we offer them genetic counseling and also offer them a germline testing upfront itself, rather than keeping it for a later date, when we would actually be tied up for time, when we have to, opt for the next line of treatment when the disease progresses. And also we see that the prognosis with the germline BRCA pancreatic cancer is quite unclear. Next slide. It is recognized that, by having a germline BRCA mutation, there is a very good response to platinum-containing treatment, and the mechanisms were very beautifully explained by Dr. Prasad just a while ago. And we also see that with these patients who harbor the germline BRCA mutations, the patients could either have history of breast cancer or ovarian cancer or prostate cancer, or they may in the future develop these cancers. Next slide, please. So we also see that the predictive response with respect to the BRCA mutation and the outcome to platinum therapy. If we would see the overall survival by the platinum therapy in stage 3 and 4, in non-platinum versus the platinum, obviously the platinum is giving better response in germline BRCA. In a similar manner, if we would see the HR, that is the DNA damage repair mutated advanced pancreatic cancer, the results with the platinum is kind of even better than having a germline BRCA mutation, which is also quite intriguing. Next slide. Now coming to the discussion of POLO trial, this is a first phase 3 trial to investigate a PARP inhibitor in patients with germline BRCA mutation. Here, the criteria for recruiting the patients was that the patient should have had metastatic pancreatic adenocarcinoma with germline mutation with a good performance status, and the patient should have been exposed to a first-line platinum-based chemotherapy for at least 16 weeks without a progression, which is what is very important in this slide, and not much of the toxicity in accordance to the common terminology criteria for adverse events. And after about 4 to 8 weeks post the therapy, the patients are randomized, and the randomization is at the rate of 3:2. Around 154 patients were recruited here, and there was maintenance of Olaparib. The first time was Olaparib 300 milligram BD, which was given for 92 patients, and the placebo was given to 62 patients in accordance to the randomization of 3:2. And the primary endpoint was PFS, secondary endpoint was the OS, and also many other parameters like the time to first subsequent therapy, time to second subsequent therapy, the time to study treatment discontinuation or death. Next slide. Now, POLO has provided the most comprehensive data set to date for the germline BRCA mutations. And we see that out of the 2,206 patients that were screened, 7.2% of the germline BRCA mutations were seen in 159 patients, which is like 96.3% of the patients with germline BRCA who were whites, and 6% had highest prevalence in US, Israel, and France, which amounted to 130 patients, and 5.1% of the patients amongst these, which is around 85 patients, were not from US and Israel, the other country patients. So overall, we see that the mutation rate is around 7.4%. Next slide. This POLO was actually a global study. So basically, they enrolled 12 countries worldwide, US, France, Israel, Germany, and so on, but there were no Asian subpopulation. Therefore, we are not really sure how the results will be if we extrapolate it to the Asian group of population. Next slide. The patients were enrolled over a 4-year period between January 2015 and January 2019. And the data cutoff was done on 15th January 2019 for the PFS analysis. And now the OS data is also out for our analysis. The baseline patient characteristics, next slide, were generally quite well balanced as in accordance to the randomization of 3:2, based on the age, sex, BRCA mutation, ECOG performance status, and also the duration of the first-line chemotherapy. We see that the duration was around 5 months. And the next slide. Over 30% of the patients on Olaparib are still ongoing with the study treatment at a data cutoff compared with 13% of the placebo arm. So that is the take-home for this particular slide, that that 30% of the patients are continuing to get Olaparib in comparison to placebo. Next slide. The liver was the most common site of metastasis amongst the others, which were also present, like the lung, peritoneum, And most of the patients did not really require a biliary stent. Next slide. We see that the patients were quite well balanced in terms of their response. And the previous chemotherapeutic agents, which were actually, the patients who were recruited were either the exposure of FOLFIRINOX or its variants, gemcitabine and cisplatin, and others as well. But the most commonly preferred option of chemotherapy that was prior given that was FOLFIRINOX. And we would see that in this slide, the median, the time on first line treatment until randomization in months was 5 months, and 16 weeks to 6 months, around 66% in Olaparib, and in placebo it is 64%. And the best response in terms of the partial response and complete response is also higher within the Olaparib arm compared to the placebo arm. Next slide. In this is a Kaplan-Meier curve, which is clearly demonstrative of the fact that the curves have, separated quite a bit, starting from the second month, which shows that the Olaparib has shown a very significant improvement with the PFS of 7.4 months versus 3.8 in placebo. So the median PFS was almost doubled with a 95% improvement over the placebo. Next slide. Twice as many patients were progression-free following the Olaparib treatment compared to the placebo, and we see that the aqua blue color is signifying the Olaparib, and we see consistently at 6 months, 12 months, 18 months, and 24 months, the response is pretty good with Olaparib. Next slide. This is a very illustrative summary of how after 5 months of the initial platinum therapy, 4 to 8 months of rest where the patients were randomized, following which the patients were given the maintenance therapy. We have seen 7.4 months PFS with Olaparib and only 3.8 months for placebo. And hazard ratio is 0.53, which is significant. We see in this forest plot, next slide. In this forest plot, we see there is a clear evidence that Olaparib is favored as all the blue points is on the left side of the median. Left side of the median. And POLO was not powered to demonstrate any difference between the subgroups. The next slide. PARP inhibitor as a subsequent line of therapy received by the Olaparib. Now, after receiving PARP inhibitor, if you would see the arm of the patients with Olaparib, not much of the patients opted to have a second or third or fourth line or fifth line of PARP inhibitor. Whereas in the placebo arm, since the patients did not respond, the patients were offered subsequent lines of therapy, either in the second, third, fourth, or fifth with the PARP inhibitors. So that this is a skewing a factor which probably has made a difference in terms of the final overall survival, which I will be briefing a little later. 23% of the patients, next slide, 23% of the patients with measurable disease at baseline had a response to Olaparib treatment. And we see the overall response rate, the CR, at least we had 2 patients with Olaparib, whereas in placebo we had nil. And partial response, we had 16 patients, whereas in placebo we had only 6. And the disease control rate, everything was in favor of Olaparib. Next slide. Over half of the patients on Olaparib had disease control at 16 weeks. And these bar graphs also shows a very good objective response and a disease control rate at 16 weeks in favor of Olaparib. Next slide. This is a final official overall survival analysis. Here we see that at 36 months, there is a gaping that is seen between the curve of Kaplan-Meier's curve of Olaparib and the placebo, 33.9% versus 17.8%. That is the overall survival in months was 19 months in Olaparib versus 19.2 in placebo. Now, this particular graph, it looks like as if there is not much difference in overall survival when we used Olaparib versus the placebo. Now, this is where we need to identify the fact that after the data cutoff, when the patients deteriorated in the placebo, the patients were actually given the second, third, fourth, fifth line options of PARP inhibitors in the placebo arm. So that is why the kind of data is kind of skewed, and it gives us a different image, as if there's not much survival difference between Olaparib and placebo here. And the next slide, the final OS subgroup analysis also, the forest plot favors Olaparib arm. There's clear shift towards the left side of the median. Next slide. The time to first subsequent cancer therapy and the time to second progression. We also see here that with Olaparib and versus placebo, the months for first and the second progression, there is a higher number of months that the patients were treated with Olaparib versus the placebo. And also the progression-free survival was higher with the Olaparib arm. Next slide. This is a long-term survivors analysis of the overall survival. More than 2 years, we see that patients who have been on Olaparib have survived. And we see that about 73.5% of the patients on Olaparib have had a very good survival comparing to the placebo arm. And the complete response also was higher. That is about 5 patients out of the 34 had complete response, whereas 0 in placebo arm. And subsequent lines of therapy was also possible with the placebo arm. So next slide. The safety analysis and the adverse events also showed that the incidence was pretty much less. So it was a very tolerable drug, and they did not see grade 4 adverse events. And in comparison to placebo, the only side effects that we actually saw was nausea, fatigue, diarrhea, abdominal pain, anemia, and constipation. The others were all quite minimal. Next slide. There was no difference in the change of the quality of life also from baseline over the first 6 months of treatment between the two arms, Olaparib and placebo. It was as if it was like, as equal to a placebo. That was how comfortable the patients were. There were no detrimental effects. Next slide. And this also shows in the graphic form how the global quality of life over time was similar in both the arms, placebo as well as Olaparib. The consistent, next slide. We see that there is a consistent consistency in the kind of side effects that we had, that is nausea, fatigue, and anemia. And as I already said, it was quite tolerable, and it never pitched more than the 3rd grade. So the patients were quite comfortable. Next slide. And adverse events of special interest, such as MDS or AML, there were no occurrences such as these. And pneumonitis, there was only 1 patient. And new primary malignancies, I think only the placebo arm had 1 rectal cancer and 1 potential event of ovarian cancer in the placebo arm, not in the Olaparib arm. In conclusion, the POLO regimen establishes a very new paradigm of biomarker-driven approach to the pancreatic cancer. It's kind of a breakthrough, result that is produced. And at 3 years, we see that 17.2% of the patients remained on Olaparib treatment versus 3.3% on placebo. Next slide, please. So we see that at least 1/5 of all the patients had a response while on Olaparib maintenance. And the median duration of the response was over 2 years. And we also did see that the overall survival, though it apparently looked like it is, kind of equal between the two arms, it is actually skewed because of the fact that placebo arm patients were given the option of the same Olaparib later on after the data cutoff. And the global quality of life was maintained, and it's a very tolerated drug. Thank you for the opportunity.
Yeah, thank you, Jovita, for
Professor Monica.
Sir, I think his screen is frozen, sir. It must be a network issue. So should we move on to the next session?
Yeah, yeah. Thank Dr. Jovita for the excellent lecture. You have covered very well about the role of Olaparip in the management of pancreatic cancer. Nice. We'll go to the next topic. Actually, the next topic should be the ovarian cancer management. However, we are going to the adverse event first. Adverse event management of Olaparip in ovarian cancer going to be given by Dr. Suresh. He is a medical oncologist working with me in VS hospitals. The chairperson, Professor Kannan, Madras. Professor Kannan, please take over.
Sir. Yes, sir. Thank you for the opportunity, sir. Now I would like to invite Dr. Suresh, sir, for the next session on adverse event management of Olaparib in ovarian cancer. The event is sponsored by AstraZeneca. Dr. Suresh, please.
Suresh, sir, you'll have to unmute your mic, sir.
Thank you, sir. Thank you, Kannan sir and Professor Subramanian sir for giving me this opportunity, and thank AstraZeneca. And I'll be sharing my screen. Is it visible?
Yes.
Yeah, yes, sir.
Thank you. So today's topic, and it has been very well presented by Prasad and Jovita. And I'll be speaking on the safety profile and management of complications with Olaparib. So today I'll be having a safety profile in SOLO 1 trial and also in POLO 1 study, whereas Olaparib in combination with bevacizumab and the complications which we had observed in POLO study. And the adverse event management strategy also will be seen, and there will be a small case study and how far the patients can be managed with appropriate management. DCGA has approved Olaparib according to SOLO 1 study, wherein it is approved for the maintenance of as a maintenance treatment of adult patients who has a deleterious or suspected deleterious germline or somatic BRCA mutations in patients with advanced epithelial ovarian, fallopian tube or primary peritoneal cancer who have a complete or partial response to first-line platinum-based chemotherapy. And according to study 19, as a maintenance treatment of adult patients with recurrent epithelial ovarian, fallopian tube or primary peritoneal cancer who have complete or partial response to platinum-based chemotherapy, and SOLO 3, and who have been treated with 3 or more lines of chemotherapy. And POLO 1 study is in Olaparib in combination with bevacizumab for above indications of high-grade epithelial ovarian cancer, fallopian tube or primary peritoneal cancer. The SOLO 1 study, we see that it was the first phase 3 trial to investigate Olaparib as a maintenance therapy in a newly diagnosed ovarian cancer. It was a multicentric phase 3 study, and patients who had a newly diagnosed high-grade serous or endometrioid variant of ovarian cancer who had completed primary or interval debulking surgery and with complete response to platinum-based chemotherapy were randomized 2:1. Patients were given Olaparib 300 milligram twice daily or a placebo. And the treatment with Olaparib was continued up to 2 years or until disease progression. And patients who had evidence of disease that remained stable would receive Olaparib beyond 2 years. The primary endpoint was progression-free survival, and the secondary endpoints were overall survival, time to first subsequent therapy, and time to second subsequent therapy with quality of life fact sheets. So the adverse event management, we need to know that what are the supportive treatments which need to be given in line with local practices. And if there is any complications, we need to have a dose interruptions, and those interruptions can be for a maximum of 14 days. And depending upon the grade of complications, we can re-challenge. Maybe we can re-challenge at the same dose at 300 milligram BD. And for subsequent interruptions, we need to have a dose reductions. Initial dose reductions will be from 300 milligram to 250 milligram twice daily, and further reductions from 250 milligram to 200 milligram twice daily. If any serious adverse events are there, or more than 2 complications are there, then we have to go in for a discontinuation of Olaparib. This is the slide which shows that the majority of patients who were started on a starting dose of 300 milligram twice daily throughout the long-term maintenance of patients in a SOLO-1 trial, they didn't have need for dose reductions over a period. So these are the patients we see over a period of 24 months, and we see that the patients was able to tolerate 300 milligram twice daily. And the initial time to complications were around 2 to 3 months. And after that, the complications were stable and they didn't have much dose reductions. The most common adverse events reported were mostly in gastrointestinal disturbances, fatigue and anemia. Nausea was the most common complications, followed by fatigue and vomiting. We had also patients with anemia, diarrhea, and constipations. And coming to placebo, still the placebo arm had nausea, fatigue, and diarrhea as common complications. And most of the complications in Olaparib were grade 1 or 2, and very less number of patients had grade 3. And most of the grade 3 complications were anemia. The management, we see that non-hematological adverse events like nausea, fatigue, and vomiting, nearly 77% of the patients experienced nausea in Olaparib arm, 63% in Olaparib arm had fatigue asthenia, and 40% of the patients had vomiting. And the median time to onset was around 0.13 months, or nearly 7 days. So that was the time duration when patient had nausea, and vomiting was around the same period of time. Fatigue and asthenia were observed in the 3rd week. And the patients who had these complications had a resolution date according to management, appropriate management. And 75% of the patients recovered very well and continued to have the same dosage in spite of having nausea. And 39% of the patients who had vomiting continued to have the same dosage. The median duration of the first event was around 1.4 months with nausea, and 3.48 months with fatigue, and 0.07 months with vomiting. This all with our experience, we know how to manage the patients who have fatigue and nausea and vomiting. So nausea and vomiting were generally reported early on, and we should clearly instruct the patients what to expect. So we should be telling them these are the nausea and vomiting can be there, and how to take diet according to that. And the median duration, as I earlier suggested, that it was very early. Within 7 days, we had this nausea, vomiting, and most of the patients were able to overcome the nausea, vomiting, and able to maintain on the same dosage. Around a quarter of patients, that's around 25% of patients who experienced vomiting, required a dose interruptions, but only 2 patients had to discontinue due to this serious adverse events. And mostly 96% of the complications of vomiting with Olaparib recovered. So we have to reassure the patients that nausea and vomiting usually improves within 4 to 8 weeks. And at first occurrence, we have to introduce an antiemetic therapy. It is always better to start with an antiemetic therapy. We can go with an antiemetic therapy half an hour before food, and having something, having the patients to eat something light before or when taking Olaparib. And if nausea and vomiting occurs despite antiemetic therapy, we can interrupt the treatment temporarily, or delay the treatment by a few days and restart at the same dose. If it persists at the same
then we can interrupt the treatment and restart at a lower dose. Nausea, in our clinical practice, we see it's mostly a low grade, intermittent, and self-limiting. Coming to fatigue, the majority did not need any intervention. But before attributing a fatigue which can be due to Olaparib, we need to counsel and have a detailed discussion with the patient. The clinical psychologist will be there, because it might be due to treatment-related fatigue or a disease-related fatigue, which the patients might be having experiencing a new form. And post-chemotherapy or surgical complications and fatigue also can be there. So we need to know what kind of fatigue is the patient is experiencing, and then attribute the fatigue due to Olaparib. 63% of the patients compared to 42% of patients in placebo arm experienced fatigue. And the time to first onset was around third week. And the median duration was around nearly 3.5 months. Mostly the management included supportive treatment, and 12% of the patients needed dose interruption and 9% needed a dose reduction. But 63% of the patient completely recovered and went on to have the most of the standard dosage. So prior to treatment, we need to advise the patients that fatigue is a common side effect and generally improves over time. And we have to pitch in with self-management resources, tell them that afternoon nap can be taken up so that we can combat fatigue, and give a referral to an exercise physiologist so that they do an exercise and keep themselves pumped up. And if there is a fatigue persisting, then we can have a dose interruption, then restart Olaparib but same or reduced dosage. And regarding psychological involvement, then we can have a pep talk with them and improve their fatigues. Anemia is the most common hematological adverse events, and 6% of the patients discontinued due to this adverse event. Apart from the most common GI toxicities, anemia was the most common toxicity experienced with Olaparib. And the prevalence of anemia over time increased from initially it was more of grade 1 or 2, and then over a period of 2 or 3 months, then the grade can be severe. But with appropriate management, this grade of anemia can be managed, tackled with either transfusion, dose interruptions, or dose reductions. We see that the median time to first onset was around 1.94 months, and a patient who had an resolution improved within 2 months. Coming to the most common management with hematological adverse event, anemia was the most common, followed by neutropenia and thrombocytopenia. And 39% of the patient had anemia, and 23% of the patients had neutropenia, and 11% of the patients had thrombocytopenia. But all were able to manage with supportive treatment, dose interruption, and dose reductions. 6% of the patients with anemia were had a discontinuation due to anemia, but coming to neutropenia and thrombocytopenia, only one patient discontinued due to this complication. And 83% of the patient had a complete recovery from anemia, 88% from complete recovery from neutropenia, and 72% from thrombocytopenia. And the most of the patients, we see that it is only grade 1 and 2, except for grade 3 in anemia, it was around 22%. All other neutropenia or thrombocytopenia, the grade 3 events are very much less. Coming to management, we see that the toxicity, hematological toxicity is grade less than 1. Then we have to see, counsel the patient regarding the frequency of hematological side effects, do a baseline testing of complete blood count, and if ensure that from a patient doesn't have any pre-existing toxicity, we have to do an folic acid, B12 or iron checkup, and whether that is causing any anemia or it is due to drug-related anemia. And following treatment initiation, we have to do a monthly assessment of complete blood count for the first 12 months, and periodically thereafter. And treatment-related anemia can be managed with transfusions without any interruption of Olaparib. And for prolonged hematological toxicities, we can interrupt the treatment and monitor blood counts weekly until recovery when we have a grade 3 or grade 4 adverse event. And if the level does not recover to an grade 1 after 4 weeks, we have to refer the patient to an hematologist for further investigation. And we have to ensure that there is an enough recovery less than grade 1 from any pre-existing or an existing hematological toxicity caused by previous chemotherapy before initiating on Olaparib. So this is the most common side effect. And coming to the summary of this safety profile, we see that monotherapy has been associated with adverse reactions. Generally, it is mild to moderate severity and generally not requiring any treatment discontinuation. The most frequent observed adverse event across the clinical trials were nausea, vomiting, diarrhea, dyspepsia, fatigue, headache, dysgeusia, decreased appetite, dizziness, upper abdominal pain, cough, dyspnea, anemia, neutropenia, thrombocytopenia, and leukopenia. The grade 3 or more adverse reactions were observed in less than or more only 2% of the patients, and most commonly it was as anemia or neutropenia, and fatigue, asthenia were around 6% of the patients. And adverse reactions that most commonly led to dose interruptions or reductions were anemia 14%, vomiting 7%, nausea 6.6%, and fatigue, asthenia around 6%. And adverse reactions that most commonly led to permanent discontinuation are anemia, it was less than 2%, nausea and thrombocytopenia less than 1%. This is the other POLO 1 study where Olaparib in combination with bevacizumab were seen in patients. And this was in patients who had a FIGO stage 3-4 high-grade ovarian cancer or non-mucinous BRCA mutated ovarian cancer, and who would have had a surgery upfront or as an interval cytoreduction, completed platinum-based chemotherapy, and we should have received more than 3 cycles of bevacizumab. These patients were randomized 2:1 into Olaparib 300 milligram twice daily given for 2 years and along with bevacizumab, or to placebo and with bevacizumab. Bevacizumab was given as 15 milligram per kg body weight every 3 weeks for a total of 15 months. The primary endpoint was progression-free survival and the sensitivity analysis. Secondary endpoint being the time to first subsequent therapy and progression-free survival 2, time to second subsequent therapy and overall survival safety profile. The adverse event which was observed in POLO 1 study was consistent with the previous trials of Olaparib, SOLO 1 and SOLO 3 trial. And we see that the nausea, fatigue, asthenia were more common, whereas hypertension was seen more in patients who had a combination of bevacizumab, and that was grade 3. Anemia also had more grade 3 when there was a combination of Olaparib with bevacizumab, whereas other complications were less than grade 1 and 2. Anemia was around 41% in a combination arm of Olaparib bevacizumab, around 41%, and 18% was more than grade 3. Whereas it was also seen in patient who received placebo with bevacizumab, but the grade was 1 and 2, and only less than 1% of the patient had more than grade 3 complication. Coming to neutropenia and thrombocytopenia, it was more, but similar to patients which were seen in a single agent Olaparib arm. And no new cases of MDS, AML, or other aplastic anemia were reported. And it was seen in around 1.1% of the patient. That was around 6 patients were observed to have Olaparib, MDS, AML in a patient who received Olaparib with bevacizumab. And coming to new primary malignancies, 7 patients had a new primary malignancy. And in pneumonitis, it was observed in both it was observed in arm which had Olaparib and bevacizumab. Around 6 patients had pneumonitis or ILD. It was not observed in patient who received placebo with bevacizumab. To summarize, we see that the adverse events with Olaparib and bevacizumab were generally mild to moderate and manageable through dose adjustment. The adverse event profile of Olaparib in POLO 1 was consistent with the previous trial of Olaparib. And after 36 months of follow-up, the incidence of MDS, AML, or aplastic anemia in the Olaparib bevacizumab arm remained consistent with the primary analysis. So these are some questions which we might take up in the question and answer sessions. That what are some challenging adverse events with Olaparib that you might have observed in clinical practice, and how commonly do your patients undergo dose reduction or discontinuation? And how do you effectively manage adverse event presented by your patients? And the other question which I would want to know is, for how long have you been having patients who have been on maintenance Olaparib? So that was the other questions which has to be from my end. Coming to adverse event management strategy, we have to support the patients proactively through the first 8 to 12 weeks of treatment. We have to manage the patient's expectations pre-treatment and tell them what is to be expected out of the complications and outcome, and reduce the impact of adverse events, and do an early intervention to manage the adverse events. And mostly it is symptomatic managed for low-grade adverse event, and if it's going to be a high-grade adverse event, you have to have a dose interruption followed by dose modification if required. The dose interruption first is we have to stop the dose interruption, and maximum stoppage will be around 14 days, and see that the toxicity is resolving to baseline or less than grade 1. If it is less than grade 1, then resume at the previous dose, or when there is a second time the complication occurs, then we can go with a reduced dose. This is a small clinical case study, and I think this is case study which has been in Australian patient. It's a 17-year-old patient who has been diagnosed with BRCA mutated and who declined an risk reduction BSO 10 years ago, and presented in late 2013 with abdominal distension and pain, gross ascites, large omental mass, and right adnexal mass, and on biopsy proved to have been an high-grade serous cancer. CA-125 was around 1980. Patient received 2 cycles of carboplatin paclitaxel and underwent an interval debulking. There was no residual disease, followed by 4 additional cycles of carbo and pacli. She required 2 units of Paxil for symptomatic anemia before the 6th cycle of chemo, and CA-125 was normal at cycle 3, and CT scan showed a complete response after completion of chemotherapy, and CA-125 was around 4. Patient was then randomized to maintenance treatment with Olaparib from, it was around March 2014. The patient had a very good progression and she was able to tolerate, but during the follow-up, she had a drop in the hemoglobin from 10.2 to 9.8, and further reduction around 7.4 milligrams in within a month of starting Olaparib. Then 2 units of Paxil was transfused, and the patient was restarted on Olaparib on the same dose of 300 milligram twice daily. 2 months later, anemia again came. Anemia was there. Hemoglobin came down to 7.8. Once again, 2 units of Paxil was transfused, and dose was reduced to 250 milligram BD. Follow-up, patient was stable and doing well. And another 6 months later, she had a drop in hemoglobin, 7.6, and transfused with 2 units of Paxil, and the dosage was further reduced to 200 milligram twice daily. In March 2015, hemoglobin was around 8.4. Patient was given a 14-day break, and hemoglobin raised up to 10.1 grams. And by March 2016, patient had completed 2 years of treatment. And at the end of treatment, a month after that, in April 2016, the hemoglobin rose to 11.5. This is the timeline graph. You see that there was a dose interruption, dose reduction, and the maintenance was well tolerated by an elderly patient. And the patient remains well in January 2019. She's aged 85 now. And on the last review, the hemoglobin was around 13. CA125 was well maintained at 8. CT scan was normal and continues to be on surveillance almost 6 years from presentation with stage 3 high-grade serous ovarian cancer. Thank you.
Dr. Kannan.
Nice presentation, Dr. Suresh. You have elaborated all the side effects of Olaparib and how to manage the side effects nicely. And then I came across one patient with severe anemia. Every month she required 1 unit of blood transfusion. And then after 7 to 8 months of therapy, she required dose modifications from 600, that is 300 milligram to 450 milligram. I have prescribed for this patient because the drugs available in our market is 150 milligram only available in our setup. And then she took the tablet for nearly 1 year. Metastatic, almost metastatic disease controlled with Olaparib was very good. Survival, it has given a survival period of nearly 1 year for the patient. And then asthenia is another very much worrying side effect with the patients. So I used to advise the patients to take rest in between the household work. If they are doing some household work, take a break in between if they are feeling very tired with the tablets. And then can be managed by motivation also.
Definitely, sir. As you said, as I have been elaborating, that anemia, we should rule out other complications also.
Yes.
And the problem is that we would have started Olaparib in third or fourth line. So the chemotherapy-induced marrow depression would have been there already. So this was the study where it was put as a maintenance first line. So the patient was able to have a good marrow and recover from. Most of our patients would have been in the third or fourth line. So
yes.
would be very less.
Thank you. Thank you, Suresh.
Thank you.
Thank you, Dr. Kannan, and thank you, Dr. Suresh, for the excellent presentation. We'll go to the next topic. It's mainly the management of ovarian cancer, the evolving paradigm shift. As you're all aware, we diagnose ovarian cancer in an advanced stage invariably. They come in stage 3 and 4, and the standard of care is a combination of platinum and taxane. It can be intraperitoneal, intravenous, 3 weekly or weekly, whatever it is. We achieve about 80% complete remission. However, only 20% go on for a long-term survival. Majority of them come back with recurrence. So we are now going to give some maintenance treatment. That's the new paradigm shift. Going to be elaborated by Dr. Suman Kalyan. He is a medical oncologist from Mayat Hospital, Chennai. Dr. Suman Kalyan.
Sir, thank you, sir, and many more happy returns of the day.
Thank you. Thank you.
I got your blessing suddenly. Thank you. So, hope my slides are visible.
Yes.
I'll start ahead. So, I'll be discussing about maintenance treatment as Sarah has already elaborated. So, I'll be discussing these topics. These are the learning objectives. I'll be discussing roughly about 20 minutes about rationale for maintenance in ovarian cancer. Then about BRCA testing, which is already discussed, why we have to do an initial BRCA testing. I'll be telling you. And then about the drug Olaparib, we'll be discussing Olaparib because there are other drugs which are approved, Niraparib and Rucaparib, which are not available in our country. So I'll be discussing Olaparib in BRCA positive or BRCA negative patients. So what is the role? And then after BRCA, we do this HRD testing. So I'll be briefing 1 or 2 words about HRD testing, and then whether Olaparib can be given in HRD positive who are BRCA negative, and then both BRCA negative and HRD negative, do they benefit from Olaparib? That also I'll give a brief, and then a take-home message for the PGs. So the rationale for maintenance treatment in any ovarian cancer is this first line. Any ovarian recurrence, it is palliation. There is no cure after ovary recurs. This we already know from clinical practice and also from various trials on surgery and chemotherapy or even radiation. So once they recur, the survival of the patient roughly around 18 months to 2 years, and the cost incurred after the turmoil, the quality of life, everything goes down, and everything comes down to palliation only. That is the rationale that I find for maintenance therapy. And then once we have an aggressive disease which can't be cured after it recurs, we have to identify subgroups. That's how cancer evolves. So cancer treatment evolves. So we have to identify some subgroups which may benefit, which may surpass this recurrence, may skip this recurrence or delay the recurrence. So we have to identify subgroups which are good and which are bad. So how to identify subgroups which are good in ovarian cancer? We hear this line from March, like say April 2020 in COVID scenario, testing is the key. The same holds good to ovarian cancer also. If we can do a testing, that is BRCA testing in the initial setting, then because I also started like most of us, like when we see a ovarian cancer patient, they'll be mostly after surgery. We just give 4 to 6 cycles of paclitaxel, then wait for recurrence. And then down the lane, we have learned that if we can identify a subgroup which may benefit from other treatments like maintenance, then we have to do the testing. Initially, testing was very costly. Now, if you do a germline testing, the minimum cost that I know of is 9,000 rupees. So that is how testing becomes the key. And then about maintenance therapy also, in today's context, in COVID-19 context, if a patient will benefit in terms of years from oral therapy, we should be giving it. So that is also one rationale. And if there is a survival for any maintenance treatment like bevacizumab or olaparib, we should be honest enough to offer it to the patient. The next thing, if the patient is affordable or not, if they can afford or not, is is the next thing, because there are very many ethical issues now. So our thing is to give the information to the patient. So this information, if there is survival advantage for some maintenance treatment, then the patient should be informed of it. So that is also a rationale for keeping maintenance in mind. And also given the text that the Olaparib is a costly drug, we also need to know who will not benefit from Olaparib. That is also important for any oncologist. So all this I'll be discussing in 1 or 2 slides. So regarding Olaparib maintenance treatment, there are only 2 phase 3 studies that we'll be discussing. 2 simple studies. One is SOLO 1, the other one is POLO 1. The SOLO 1 is for patients who are BRCA mutated, and POLO 1 is for these 4 groups of patients, that is BRCA mutated patient, non-mutated patient. Then they do HRD positive, HRD negative, and both negative. So any subgroup, do they benefit from Olaparib? The second thing in POLO 1 is they have included bevacizumab also in the maintenance, because pre-Olaparib, that is the only drug that has some benefit with maintenance. So that is also included in POLO 1. So these 2 are the trials for postgraduates. And then I'll discuss one by one. One is the SOLO trial. SOLO trial, as I told, is for patients who are BRCA positive. These are newly diagnosed advanced stage pain, that is stage 3 and stage 4, high-grade patients who undergo surgery, and before any treatment, they undergo this BRCA testing, either germline or somatic. Performance status should be good, and they do undergo cytoreductive surgery at some point, either before chemo or after chemo. And then after that, they're divided into these 2 simple arms. One arm received Olaparib in the standard dose of 300 milligram BD. Other one is placebo, same tablet, but not Olaparib. So, and then this treatment goes on for 2 years. So past 2 years, if the patient has no evidence of disease, all the treatment stops, but then they're observed for another 1 or 2 years also. But patients who have a partial response, who have disease remaining, they just continue the same Olaparib. The primary endpoint of solo one is PFS. Secondary endpoints include PFS1 and PFS2, overall survival and quality of life. So what is this PFS1 and 2? PFS1 is time from randomization to the start of next therapy or death. The PFS2 is time from randomization to second subsequent therapy of death. So this is nothing but prolonged observation of the results. That is, do Olaparib really benefit in patients in 1 or 2 lines, not just stop at progression, just continue the observation. And also this point is also unique to the trial. They observed patients even after stopping the treatment at 2 years, and then observing the patient, do they really benefit from the drug. So that is also unique in the trial. And one thing in the trial is that more than 50% of patients in the Olaparib completed treatment. So that itself is a success for the treatment, because most of the ovarian trials, as we know, they don't complete treatment. There are trials, well established trial in which only 30% completed treatment. So these are the results for solo one. At the end of 2 years, there is a wide separation of the curves, as you see. And the end of 5 years also, if we observe progression at 5 years, 48% of patients are progression free at 5 years compared to 21% in the placebo arm. So this is a very significant difference for any ovarian cancer trial that we know of. So that was the primary endpoint. So and other secondary endpoints is Olaparib reduced the risk of progression or death by 67%. 67% also is a big number for ovarian cancer. And that is about the results of the study. This is about side effects, which was already mentioned and discussed, so not going into it. The most common side effects that I observed in my set of patients were the same. That is, main thing is fatigue. Most of the patients will have fatigue and asthenia. Most of the patients don't have nausea. I don't know why. Maybe because they are already used to chemotherapy. The other thing, of course, was anemia. Anemia is a limiting side effect. So the take-home messages from solo one is that maintenance Olaparib is very beneficial in patients who are BRCA mutated, either somatic or germline. And there is 67% reduction in risk of disease progression. This is the hazard ratio is 0.33, and p-value is very significant. And after this study, the median PFS was 56 months on the Olaparib arm versus 13 months for the placebo arm. And PFS at 5 years was 48 versus 21%. So all this led to the use of Olaparib in the first line after completion of chemotherapy, especially in patients who are BRCA mutated. So any patient initially, if we do a BRCA mutation, we can keep the drug in mind if finances are not a constraint. So this is about BRCA mutated patients. Next question, the big elephant in the room is BRCA negative patients, because we know only 15 to 20% of patients of ovarian cancer are generally BRCA positive. So what will happen to BRCA negative patients? So generally, as we know, in a clinical setting, you do use bevacizumab as a maintenance for any patient on ovarian cancer. So if they are BRCA negative, we are going to use bevacizumab if cost is not a constraint. But then do we identify another subgroup which will benefit from Olaparib? So the answer is given by this HRD testing. The HRD testing, it costs around 17,000 rupees currently. I don't know about other testing. So the minimum cost that I know is BRCA testing costs 9,000 and HRD testing will cost 15,000 rupees in the minimum. So this HRD testing will include these genes. What is HRD testing is nothing but including these genes in the panel apart from BRCA1 and BRCA2. So this comes from the prostate study itself. So these are the number of genes that define HRD. So 15 number of genes including BRCA1 and BRCA2. So if one of these genes are positive, then they become HRD positive. So what do we do? Where do we do HRD testing is when a patient is there and we do BRCA testing and BRCA comes negative, but we know that patient may be BRCA. We have a strong clinical suspicion because there is a strong family history, or the patient has breast and ovarian cancer, or one of the relatives has suppose a male breast cancer. We have a strong suspicion of BRCA, then we go ahead and do HRD reflex testing. And then if the HRD is positive, then they do benefit from Olaparib, that is tested in the subsequent trial, that is POLO 1 trial. And what happened to, again, if the HRD is negative again, do they really benefit from the drug? That will be discussed in the POLO 1 trial. So this is about POLO 1. POLO 1 is about Olaparib in newly diagnosed patients treated with chemotherapy along with minimum of 3 cycles of bevacizumab in the initial treatment. So obviously these patients are high risk ovarian cancer, that is stage 3 and stage 4. They may not be BRCA mutated at selection. They undergo surgery, then they undergo chemotherapy, then they are randomized to these 2 arms. One arm will receive, both arms will receive bevacizumab for 2 years. The trial arm will receive Olaparib for 2 years. The other arm will receive placebo for 2 years. So at the end of the study, the primary endpoint was PFS. The secondary endpoint, again, the same like solo 1, PFS 1, 2 were tested. Overall survival, safety, and quality of life were tested. Even the testing methods were a secondary endpoints to compare them. Now, these were the results of POLO 1. So generally, in the general population, unselected patients, these were the results, that is 22 versus 16 months. So are we interested in knowing this? No, because we already know that Olaparib do benefit patients who are BRCA mutated from the solo 1 trial. So we want to know what happens to other people. So in POLO 1, approximately 50% of the patients were HRD positive. So do HRD patients benefit from Olaparib is the question. So this is the pie chart showing how many patients in POLO were belong to which arm. So HRD positive was there in roughly 48% of the patients. So this graph is from the original trial itself. We see that in the first, first graph, there is wide splitting of the curves. So when there is a BRCA mutation, they do very well with Olaparib with bevacizumab, obviously. So when the second curve, that is patients who have HRD mutation, if you see the left upper and left lower curves, they are almost similar. Means to say that if the patients are HRD mutated, they behave same as BRCA mutated patients. So any of the 15 genes are positive, then we should be offering Olaparib along with bevacizumab. That is the model of POLO 1. The other remaining 2 curves, we can see that if patients have no BRCA mutation but yet have a HRD mutation, they do benefit somewhat from Olaparib. And the top right curve, we can see that this is the minimum difference we can see in the trial. So if the patient doesn't have BRCA or HRD mutation, they're not going to benefit from Olaparib, as is seen in this key subgroup PFS data. So intent to treat population, if all the patients put together, there is some benefit of adding Olaparib and bevacizumab in the maintenance. The patients are mutated, that is BRCA mutated, yes, there is a significant difference. So the difference in median PFS is 15 months. And the patients are HRD positive, then again, the difference in median PFS is 19 months. So HRD and BRCA doesn't make a difference when we give Olaparib with bevacizumab in the maintenance, as is seen in POLO trial. So the last one is important for me. So the patients are HRD negative, then there is no benefit of adding Olaparib. So if you want to select a patient, only for bevacizumab maintenance and not give Olaparib. So these are the patients, that is, we have to do BRCA testing, they're negative. Then again do reflex HRD, that is also negative. Then there is no benefit of adding Olaparib. So that is the in inference from the POLO one that I can infer. So this again is the same plot given in bar chart. So overall, the difference is about roughly 5%. If they are BRCA mutated, the difference is 20%. HRD again, it's 20%. If the patient is HRD negative, as you see in the last part, there is no difference. So we should be avoiding Olaparib in the this is about side effect profile, which is already discussed. It is same as POLO. There is as solo, just nausea, fatigue, hypertension, and anemia are the common side effects. And these three side effects are black box warning for bevacizumab, but then the incidence in both the trials is only around 1%. So in the COVID era, we should be knowing about pneumonitis also. Pneumonitis is there in 1% of patients who received Olaparib in both the trials. So the incidence is just 1%. So new primary malignancies and MDS, that is AML and MDS, there are not much difference, but there is 1% incidence of pneumonitis in these patients. So takeaway for POLO1 is that POLO1 is a phase 3 trial for patients who are unselected and then they received bevacizumab with Olaparib. So the inference from the trial is if the patients are BRCA positive, then they benefit from bevacizumab with Olaparib. If they are BRCA negative yet HRD positive, they also benefit from Olaparib. If they are HRD negative and BRCA negative, they don't benefit. So that is as simple as that. So this is from FDA approval. So Olaparib is indicated in these indications. So I discussed only about first line maintenance. So in first line maintenance, if the patient is BRCA mutated, we give the drug for maintenance as a single agent. So that makes more sense in the COVID era. Just give oral tablets. And if they are HRD positive, then but BRCA negative, we should be giving bevacizumab along with Olaparib. So that is how the indication also is stated. And for recurrent settings, if there are more than 3 lines of chemotherapy already, we can be giving Olaparib for any patient. And also in the second line maintenance, it is indicated for many cancer like high grade epithelial ovarian cancer, then fallopian tube and primary peritoneal. It doesn't matter. So it is indicated in the following FDA approval. So this was my first slide. In the past 20 minutes, we discussed about rationale for maintenance in ovarian cancer. We discussed why we should be doing initial BRCA testing rather than doing it in the later setting at recurrence. And then we discussed about Olaparib in BRCA positive or negative patients, and then Olaparib in BRCA that is HRD positive or negative. The take home for PGs and other people here is that we should be doing BRCA in all ovarian cancer patients frontline, because the guidelines change for NCCN to ASCO to Gynec Society. The guidelines are different, but then we should be doing in all our ovarian patients, because even if the patient not affordable for Olaparib, we know that patients who are BRCA positive, they'll benefit from cisplatin or addition of platinums. So that is one simple inference that we can get. And then the other thing is the patient is BRCA positive, should be offering them just oral maintenance with Olaparib. They are BRCA negative, then go ahead and do HRD testing only in patients who you suspect them to be BRCA positive, that is BRCA-ness is there, then we go ahead and do this HRD testing. If HRD comes positive, then the maintenance should be bevacizumab along with Olaparib. If they are HRD negative, that is both BRCA and HRD negative, we should be offering only bevacizumab as maintenance. So this may be the take-home message about maintenance treatment in first-line ovarian cancer.
Thank you, Dr. Suman Kalyan, for the excellent. You have summarized it very well. The take-home message are really useful. And now we'll go to the last session, case-based discussion. Chairperson, I think is myself. Dr. Nitya, are you there?
Sir, Dr. Nitya will not be able to log in.
Okay,
and
no problem.
Dr. Kripa Shankar will also not be able to log in, sir.
Yeah, I know. Right. So the case-based discussion. The moderator is going to be Professor Ashish Singh from CMC Vellore. The panelists are going to be Dr. Suman Kalyan, Dr. Suresh, Dr. Prasad Eswaran, Dr. Jovita Martin. Professor Ashish Singh.
Very good evening, sir, and congratulations, and thank you for having all of us here. And I think the last 2.5 hours has been
2 hours.
Panelists actually have spoken really well, and so I thought we will just probably put everything in context. And I do have slides, but I think when I put slides, I'm not able to see you all, and then we're not able to talk. So we'll use slides only if required, and let us just put everything, because it's been it's a really long evening and lot of data shown, lot of discussion. So let us make things simple and decide how we can use what we learned today for our patients. So Dr. Jovita and Dr. Prasad, I can't see you all. I hope, are you all there?
Yeah, Ashish.
Yes, hi. Okay, so let's so I think the first discussion we'll discuss it in 2 parts. One is ovarian cancer, and the next maybe pancreatic cancer. So just to begin with the discussion on ovarian cancer, I think the whole evening we were discussing maintenance therapy, right? One maintenance, predominantly PARP inhibitor maintenance, and we know that in ovarian cancers, PARP inhibitor is not the only maintenance, right? We have since a lot of time we have been initial years. Dr. Subramanian will know that there were trials of chemotherapy maintenance, right? Paclitaxel, metronomic chemotherapy, platinum maintenance, and then there was this period of bevacizumab maintenance, and now we are seeing PARP inhibitor maintenance. So just a general question on, even though Dr. Suman strongly propagated maintenance PARP inhibitor, my question is in general, Dr. Prasad or Dr. Jovita, do you really see a value in doing maintenance therapy in a disease like ovarian cancer?
Basically, looking at the platinum-free interval or the time taken for the relapse once the first-line treatment is over. So either bevacizumab or Olaparib is going to help us prolonging the first progression-free survival, so that patients would, if there is a relapse, it's going to be more of a platinum-sensitive relapse, and we'll be able to reintroduce platinum, which offers a better response in the recurrent setting. And
that's an interesting point. So the point you're raising is, if you're able to push the relapse further down, those patients will probably be more sensitive to platinum.
These are the patients who will be more of so again, platinum adds much better than any other drug in the BRCA positive.
Yeah, thank you, Dr. Prasad. Dr. Jovita, you were saying something?
Yes, Ashish, I was about to say the same point as Prasad, but however, I just want to add one more point that apart from the fact that we are advocating Olaparib as maintenance therapy, in cases where we are not able to give this drug because of cost, so in those cases, we would definitely recommend oral metronomic chemotherapy, which also I have seen in practice really increases the time to relapse.
Sure. So you are also propagating some kind of maintenance. If this is not possible, at least some other maintenance. Now, let me go back to Dr. Suresh. Dr. Suresh, what in your practice, do all patients get maintenance, or there are many who actually are just observed after first-line therapy?
My practice is mostly observation if they are in a stage 1 to 3, except for stage 4.
Right. And I think all of you have your own points, and I think for the younger people in the audience, and the reason why I say all of them have their own advantages and disadvantages. I think the best advantage of an observation is that your patients don't have to monitor, you don't have to do scans, don't have to come to hospital, don't have to face any financial toxicity or even the toxicity of the drug. And till now, whatever trial we have discussed so far in the first line, I am yet to see an overall survival gain from any of these strategies. With bevacizumab, I think there is a little bit of a gain, but that is also in people who have a very high risk disease. Those are patients who are suboptimally debulked. So as of now, the best what we can do is an excellent surgery, maybe a HIPEC if possible, and the outcome actually depends on whether the patient has residual disease or do not have residual disease. And as Suman said in his talk, that I mean, we're not curing anybody here. Most patients will relapse, and it's not that if you have not used these agents upfront, you will not have an opportunity to use them later. Now coming to another maintenance, like I mean, Suman, because let's talk only about Olaparib because the other two drugs are not available, Niraparib and Rucaparib. But if you see, in Niraparib is the only trial which took patients unselected. I mean, they took all comers, except I mean and as a single agent. So in the two trials which Suman discussed, one was the Paula with Bev, and one was Solo one single agent, but only in mutated patients. Now, Dr. Suman, what is your take on giving both the drugs upfront as maintenance? Would you want to use two effective agents upfront, or you would want to keep one for later use?
Means Olaparib and bevacizumab, you're asking, huh?
Yes, because those are the two agents which are effective. So do you want to use up both of them upfront, or you want to keep one for later use?
So as I told in my slide presentation, we just identify subgroups. So one subgroup is BRCA mutated. So once they are BRCA 1 and 2 mutated, I don't see any necessity to adding bevacizumab. I'll be giving Olaparib as a maintenance. If they are BRCA negative, but they're you suspect BRCA-ness in terms of clinically, so then I go ahead and do HRD testing. So if they are HRD positive, then I'll be offering bevacizumab to these people.
Correct. So the point you're bringing out is if you do not have a BRCA mutation, even in the Paola study, the benefit, the curves, the hazard ratios was not very impressive, especially in terms of PFS, right? And it's not what you've seen in the Solo 1 trial, where the curves are continuing to be separate even at 5 years, at 5 years. So knowing whether somebody has mutation, it actually makes a lot of difference, right on Don. And that is one reason why we should be doing the germline testing. At least by the time patient is finishing chemotherapy, we should have the result in hand.
Yes.
Result in hand.
Roughly
Dr. Jovita,
7% extra we derive, sir, by doing HRD testing. So this only 5 to 7% will be offering both the agents.
Sure. So Dr. Jovita, what is your take on this? Do you want to spend money on NGS on tumor tissue or HRD testing, or you would use these drugs later irrespective of the HRD?
I would definitely want to go upfront testing whenever feasible, whenever the patient is financially affordable, because it gives us a better understanding of how we could actually manipulate, use the permutation and combination method to go next line. So it'll help us plan ahead of time.
Yeah, so it's a good information to have, and if you look at the cost of the test, is nothing is compared to the cost of the drug. So if someone who can afford the drug might as well afford the test, and I think in the trials what they have done is they've just tried to look at patients who are the patients who are benefiting. I mean, even when they don't have the mutation, and that's how they come up to this HRD score. Yeah, so it's like you can use it as a biomarker. You can use it as a biomarker if it's available. So now the next question I have is about the duration of treatment. Now, 2 years duration if you're using it upfront. Even though we have seen, I mean, in the talk on the toxicity and all, we did not see too much of toxicity, but I think recently I saw the Solo 2 overall survival. Now, Solo 2 is actually a second-line trial, again in mutated patients. There they're talking about an AML MDS risk of about 8%, 6%. So, Dr. Suresh, anyway, do you really see, because we are not yet seen an OS benefit, and you're talking about 2 years therapy, and most patients will probably take 2 years because if you're using it upfront. So even though Dr. Prasad said that they may respond better, but how about the effect on the marrow to subsequent lines of chemotherapy? Are all these concerns?
Yeah, definitely. as I have been saying, that in Indian population or in our population, we have not tried Olaparib as a maintenance therapy in upfront. Most of the patients what we see or where we have given Olaparib is always mostly in the second or third line of recurrence. So we need some time to understand what effect Olaparib is there as a maintenance upfront. Second, if the patient can tolerate up to 2 years. Because most of the times when we have been giving it is in the third or fourth line, patients will not tolerate more than 3 months. We have seen much complications and all this stuff. So unless we give them as a maintenance therapy, we can really don't know whether it is going to be tolerated by the patients for 2 years. Only if it's tolerable for 2 years, then we can think about second malignancies or MDS AML transformations.
Yeah. Anemia, as I rightly pointed out, even the case discussion is very common. Even right now, we are actually having a phase 4 trial in which most patients are requiring dose reduction only for anemia, and because it's a pain to keep transfusing every 2 to 3 months, so we end up reducing. Anybody else wants to share any experience of any other toxicity they have encountered? Anybody else who has used this drug?
After about 10-12 months, there is mild peripheral neuropathy also. I don't know whether it's reported. For my patient, I've seen.
Sure. I mean, I've had 2-3 patients who took, I mean, they were all carriers, mutation carriers, so that's why they took for long. And they had some GI upset, abdominal cramps, nausea. So initially, at least, it all gets, most people will actually reduce the dose themselves, and then they will come to a dose which suits them. And that's how it is. So therefore, I think, I would personally wait, especially if you do not have a mutation. I would personally wait for the overall survival results, especially because we don't know the later effects of these drugs. Now, today's presentation, we didn't talk about anything in later lines, but maybe Subramanian sir, you can add. You would have seen this drug used in so many patients in later lines. As somebody also said that most of our patients are on third, fourth line. So, have you seen any single agent activity, because those patients are not exactly maintenance, there we are treating disease?
Yeah, actually, because of the financial involvement, we have not been giving this drug for many patients. Only a few of them have received it. But as Dr. Suresh has pointed out, they develop side effects and anemia and other complications. So we are not able to go on for a longer period. So recently, we have started a few patients of maintenance upfront as a single drug in BRCA mutated patients. It remains to be seen how they are going to take it.
Right.
So the main thing,
sir.
I think, is a financial thing.
Right. Yeah. Even in, I think there is some immunogenicity or immunogenic potential of these drugs, because for the curves to remain separate at 5 years, for a treatment which is stopping at 2 years, there is probably something else going on there. We really don't understand what goes on there, and it's a good thing to have. Now, okay, so anything else? So Suman, I mean, even though you discuss about other, you didn't talk about other drugs like Niraparib or Rucaparib. Do you feel that they're all same, or you think they will be, if tomorrow if all are available, would you prefer one over the other?
So honestly, I don't have an experience, but then going by the trials, I think the activity is going to be the same. There may be some difference in the side effect profile. So
yes, correct. And also, I think the whatever the median PFS we see, it depends entirely on what kind of patients you put in the trial. So for patients with biomarker positivity, they're always going to do better. And that's why I think in the primer study, the PFSs are much lower, but because they've taken all comers. Okay, so Jovita, anything else you wanted to add in the ovarian discussion? Then we'll probably move on to the pancreatic discussion.
Nothing else, Ashish. I think it's quite comprehensive a cover that you've given.
Sure. So now let's move on to pancreatic cancer. So I think Jovita, you've discussed the trial design. So it was we have only one study, and all the patients in the study actually had a germline mutation in the and they all had pancreatic cancer. So my question to Dr. Jovita is it common, Dr. Jovita, or in the trial, did they have to screen a lot of patients?
Ashish, I didn't follow your question completely. You asked me if
My
all the
question
patients
was,
were
the question was, it's a multi-center trial, multiple countries. I mean, they did the trial in many countries. So was it easy to find patients with pancreatic cancer who have a germline BRCA mutation? Like in terms, or how when do we suspect? Do we suspect based on family history, or do we just do everybody's blood test or tumor testing? How do we go forward? How do we select a patient who will be eligible for?
As you say, as you very clearly said, I mean, it's the right suggestion that you'd given, the family history and, the history of the kind of symptoms that the patient gives or the age of the patient, all these will definitely contribute to this. But in this particular trial, it doesn't look like just a group of patients were screened. It looked like a huge number of people, more than 3,000 were actually screened, and amongst them only 150 and odd patients were found to have germline. So it is not that they were biased against a particular group of people.
Yeah, so we are actually looking at a biomarker which is not very common. Okay, let's now come to Dr. Prasad. So Dr. Prasad, what is your preferred first line therapy for pancreatic cancer in a fit gentleman?
We're talking about adjuvant or metastatic?
Metastatic. Today is only metastatic.
The combination of either nab-paclitaxel, gemcitabine, or FOLFIRINOX. Both are category 1 recommendation for the.
Right. And Dr. Prasad, do you how many cycles do you give them? Do you stop at 6 cycles, or do you keep giving till they're tolerating? How do you treat them?
We generally stop at 6 cycles because paclitaxel, again, nab-paclitaxel is going to have more of neuropathy, and we do have more of diabetes in our patients, being pancreas than the primary setting. So they won't tolerate the side effects of continuation of nab-paclitaxel because of the side effects. So we generally put them off after the 4 to 6 cycles based on the serious adverse events. And then
So what you're saying is this, because this is such a disease with such a poor prognosis and limited treatment options, we'll give it till they are benefiting or they're tolerating, isn't it? So we end up stopping because of poor tolerance. Yeah, we end up stopping because of poor tolerance. And how do you decide your second line options? I mean, do you just switch over to the other regimen which you have not used? I'm asking all these things because in this context we're going to look at the trial. So yeah.
So what I personally do is kind of stop paclitaxel and then put them on a single agent gemcitabine because it's much more patient friendly, and kind of all the metastatic patients needs to be on some form of a treatment. And then subsequently we can evaluate the BRCA, and if positive we can put them on Olaparib. But again, using such an expensive drug for a disease like pancreas is
so that's the question which actually I had. Dr. Jovita, what do you think about comparing this drug against placebo? I mean, and these are patients who are actually responding, and then you take them off chemo and then you randomize against this tablet versus placebo. So as Dr. Prasad was saying, we could have continued the same chemo or given some gemcitabine or something else.
I think the same question goes on in my mind as well. Having such a a terrible disease to tackle, to keep the patient on a placebo doesn't sound right to me as well.
Yeah, so that's a concern actually. When you read about this trial, that's what most people have had. That this is such a dismal disease. Number one, the endpoint of the trial should have been overall survival and not a progression-free survival. And even though we are able to show a PFS, but we are able to show a PFS gain opposite against a placebo, and not against any chemotherapy. So that's a concern. However, if you see the data, this drug is clearly active in this biomarker selected group. So let me come to someone who's not spoken. Dr. Suresh, so tomorrow, if there is a drug, if there's a patient who has access to this drug and he's mutated, where will you position this drug and how will you use it?
Definitely, if it's going to be an affordable and patient has gotten a good performance status, I would definitely take it up.
Right. So you would wait for him to progress on your first line chemotherapy and then you will put it?
Complete the first line until he manages or tolerates the first line treatment. We'll end with one line of management, and only if the progress is on that or not able to think, I'll be going for the second options.
Yeah, that's probably what we all would do. Dr. Prasad, I mean, for patients, if you know they have a BRCA mutation, would you prefer a platinum over gem-nab-paclitaxel? I mean, that's just something which comes to my mind. And even if they're not fit for FOLFIRINOX, would you should we be treating them with like a maybe oxaliplatin alone or carboplatin cisplatin?
Yeah, BRCA positive patients do have the specific sensitivity to the use of platinum. So probably after a good cytoreduction or the tumor burden, once it's come down, which probably is much better with nab-paclitaxel and gemcitabine, probably we can switch it over to any form of maintenance with the carboplatin or cisplatin as a single agent. Though we don't have really trials which had said about platinum maintenance in all these drugs. But really, when compared to, I would still not be quite convinced about Olaparib with the use of BRCA positivity in pancreatic cancer because of the overall survival is not that great, and we didn't really have a good difference in the overall survival and compared to like ovarian carcinomas.
Yeah, and I think, I don't know if I can share my screen, and I think that is possibly to do with not many patients got any subsequent line therapy because once the progression. So this is the PFS. This is the PFS which Dr. Jovita showed us. And if you see, almost at 6 months, almost half of them have progressed, and that's the OS. So small trial. I mean, numbers are small, 90 and 60, but and then I'm not sure about the crossover and all that. I have not read the full text. But based on this, at least, even though it's an effective drug, but we're not sure how long the effect lasts. And the other challenge, I think, which we all didn't discuss is the tissue testing, because in pancreatic cancer, it is so difficult to have a good biopsy. And so, Dr. Suman, do you think, like, is there a role for liquid biopsies in this disease? Should we do somatic testing also, or as of now we should just restrict to germline testing for pancreatic cancer patients?
For pancreas, my personal opinion, it is fishing in troubled waters, because we don't, as you rightly told, we don't find patients who survive more than 10 months, 12 months. So if we can identify a subgroup which will benefit from Olaparib, we're prompt to give it. So regarding the testing, yes, sir, I think liquid biopsy will come up in prostate. But right now we do tissue testing only.
Sure. So I think that those are all the questions I had. Anybody else wants to add anything or want to discuss anything?
Comfortable are we to prescribe Olaparib maintenance in pancreas? It's quite a disappointing disease. We really do not have any big data to say that it has been quite beneficial.
Yes, I mean that is when the drug was studied in this kind of a trial. However, if you actually have no other option left, especially like if you have exhausted your first line chemo and including platinum 5FU, there is not too much data to say that using like a taxane also in later lines a single agent or with gemcitabine would help. So when usually we will say best supportive care, that is the time where we can consider this drug. And also, this is a trial only in pancreatic cancer, but what about other biliary cancers? Because a lot of our cancers are actually not pancreatic. It could be cholangios or even bile duct. So we really don't know whether the same thing can be extrapolated there. Dr. Suresh, any last comments from you? Biliary tract cancers.
I just wanted to know your experience and how long the patients have been on Olaparib in the maintenance arm and in metastatic arm? How long you have been giving them, and what is the
Sure,
maximum duration of Olaparib the patient has taken?
Sure. So I think so. I mean, from whatever experience I have is on clinical trials because the drug is very expensive for someone to afford it for long. But on the clinical trial, I've had two sisters actually. Both of them are germline carriers, and they both survived with metastatic disease for more than 5 years. And it's of those 5 years of maybe they would have taken Olaparib for 2.5 years. And we were able to use Olaparib actually after a re-response to platinum. So it was like once they had a relapsed disease, they had a re-response, they were on Olaparib. Subsequently, when there is progression, you can discontinue Olaparib, you can give chemotherapy, and you can put them again on Olaparib maintenance. So both of them actually went on for more than 5 years, and sadly one of them succumbed to COVID last year, and the other sister is still alive, but she has now she's off Olaparib. The disease is bad. She's on gemcitabine, bevacizumab, but in those, yeah, and maybe in my short experience of about 7-8 patients, 3 or 4 were the long-term responders, and most of the other patients, they progressed after about 6 or 9 months. So it's not that everybody, even though look at the curve, the curve does drop at the beginning. Yeah.
Thank you.
Sure. So thank you, everybody. Stay safe. It's just another month. I think we have to bear with this, and and hopefully, I mean, we said the same thing last year, but hopefully there will not be any third wave. Even though everybody is not being protective and saying there will be a third wave, I feel there will be no third wave.
Thank you, Professor Ashish Singh, for the excellent discussion. Now, I thank all the participants, the chairpersons, for the excellent interaction we had. We have some knowledge about the role of PARP inhibitors in the management of ovary and to some extent in pancreas. I'm sure that in high-grade ovarian cancers, to some extent, almost all cancers, we should do BRCA mutation and necessary HRD also. Now that the cost has come down, we should be able to do that, because it definitely has a role in the management of ovarian cancer. As far as pancreas is concerned, our first-line treatment is usually platinum and gemcite. We are really happy with that combination. There's very not much of side effects, and we are able to get good remissions. Some people respond very well, some people have a partial response. In such situations, we have added bevacizumab also. We get a better response. But overall, pancreas is a difficult disease, a disappointing one. And in BRCA mutated cases, the role of Olaparip is definitely to be considered. So far, we have not used Olaparip in any one of our pancreatic patients. I think we will consider that in future. But at the moment, we have had some idea about the Olaparip, its indications, its side effects, and how to manage that. So I thank AstraZeneca for sponsoring this event, and I thank all the participants for the excellent interaction. Thank you all.